a trial we call the Ariel 2 trial. This is a phase 2 single-arm trial conducted in women with platinum-sensitive recurrent ovarian cancer who had measurable disease. And the idea was to not only take a brief look at the activity of this particular PARP inhibitor in women who carried a germline mutation in BRCA, but also to look at a group of patients that were identified as not having a germline mutation germline or somatic mutation in BRCA, and see how the drug performed in that group of patients. We've known for some time that the group with the highest expectations for activity were patients who carried a germline mutation or somatic mutation in BRCA, and we have known in the past that there were patients with high-grade serous ovarian cancer who did respond to a PARP inhibitor. But what this particular study was doing was trying to identify a cohort of women through a genomic analysis, a prospective biomarker, for instance, that could identify those women ahead of time. So what we did is we enrolled essentially 3 cohorts of women. There was a group of women who we knew were BRCA positive, germline, and those patients we capped out early on the trial to 15 patients. And then we opened up the BRCA negative patient population and stratified them on the basis of whether or not they had a large amount of what we call genomic scarring, which was essentially represented by a diffuse amount of genomic aberrations across the genome through a SNP array. And what we found was that there was probably a critical cutoff that was generated through 2 data sets, 2 independent data sets, as a way to discriminate women who had a lot of this heterozygosity and not so much. And through that dichotomization, developed a decision point for women going on the trial who would be anticipated to be at risk or at more likely than not to respond. So we termed those patients as loss of heterozygosity high and loss of heterozygosity low. And so then the 3 buckets were BRCA, LOH high, LOH low. And so what we did then was to enroll patients into those particular cohorts. And what we were excited to see was that it was actually the model performed very well. So for the patients who had the BRCA mutation, we saw the high rate of expected response rate, 70% by RECIST, 80% by CA25 RECIST. But, and in the negatives, importantly, we saw very little activity. So we had a 13% response rate in the biomarker and BRCA negative cohort. The middle group, the ones that were BRCA negative but had this loss of heterozygosity, we saw over 30% response rate, and even higher if you add in the CA25 responders.